Hi, it's Professor Pikett here. We're going to talk about diabetes today. There's not a lot here that I really want you to hyper-focus on. I just want you to be aware of it. And I know you got a lot of this in med-surg, so this is just really kind of a quick recap and a brief discussion on diabetes insipidus and diabetes mellitus. There are three cellular components that you should know about the endocrine system. There are the glands, which send the chemical messengers, and there are the hormones, which are the chemical messengers, and then there are the receptors in the various organs that receive the chemical messengers, right? So hormones really are the ones who are kind of like the Amazon driver. They get the message from the glands, they travel around the body at great speed, they find their target organ or receptor, and then they deliver the message that's supposed to be there. Diabetes insipidus, again, I'm not going into great deals about all of these. You should have gotten a lot of information from med-surg, but I, again, want to touch base and let you know that both of these situations can happen in the pediatric world as well. The principal disorder of the posterior pituitary gland that is a result of not enough secretions of the antidiuretic hormone is diabetes insipidus. So your pituitary gland is not making enough ADH, and this causes an uncontrolled diuresing, and it causes an uncontrolled thirst. This can be caused either idiopathically, like there's no real connection. It can run down the family lines. Some of the causes that we look for immediately are tumors, those pituitary tumors, right? Or trauma, car accidents, head injuries, things like that. Any kind of central nervous system infection like meningitis could cause it. And then, of course, aneurysm. So those are the things that we rule out before we just get to idiopathic. The things that you really need to know as a nurse is when you see somebody who's lost a lot of weight very, very quickly, they have an uncontrolled thirst. Like, you can give them a gallon of water and they will drink it and they will still be thirsty. They want to drink a lot of water, right? And they are complaining that they are going to the bathroom all the time. You're gonna do their baseline glucose, you're going to do their baseline labs that are ordered, CMP, CBC. We just want to make sure everything baseline is where it's at, make sure that we're not hiding cancer, tumors, major infections, things like that. We're going to monitor our I's and O's because we're drinking and peeing a lot. We're going to monitor our vital signs. We want to make sure that there's no infections and underlying diagnosis complications that we're missing. The biggest thing with this with nurses is we are going to treat it by replacing your antidiuretic hormone, right? If your body is not making enough of it, the way to treat it is to give ADH. It is through medication administration, so it's really important as nurses to talk about the fact that this medication is essential all the time for the patient to continue doing well and to improve. So it is strict adherence to that medication. You're going to do follow-up visits probably through endocrine. They'll have some primary plan of care that they'll do checkpoints in once they're stable. And you really, as a nurse, need to focus on when they need to seek help, when things go bad, when they're really sick, when they run out of medication. Maybe they're taking the medication and the dose they're taking isn't holding them anymore. They're starting to have side effects for it, right? So we're going to talk to them about that. When we give the ADH replacement, it's the most common one is vasopressin. We can give it nasally, IV, sub-Q, and IM. So we're going to teach how to administer that medication as well. Depending on the age, right? If you can educate the teenagers or preteens, or you're going to have to provide that education to the parents as well. So the other one is diabetes mellitus. This is where the hormone that is lacking is the insulin, and the insulin's message is to deliver the glucose into the cells. When you don't have enough insulin, or you cannot get the insulin to carry the glucose into the cells, then you have diabetes mellitus, right? Peak incident for this is between 10 and 15 years of age. Usually in children, it starts to present as diabetes ketoacidosis. You do have increased risk for African American and Hispanic children, and this is the most common endocrine disorder in children. Here's your differences between your type 1 and your type 2. Type 1 is usually an absolute insulin deficiency. You don't have insulin to carry the glucose into the cells. In type 2, it tends to be insulin resistance. Maybe you're making insulin, you're just not making enough. Or maybe your insulin is very stubborn and it doesn't want to carry the glucose from the blood into the cells. Type 2 usually arises after the age of 45, but remember that we have a lot of migrant patterns in our world, and when we relocate people out of their normal cultures, their normal diets, they are at risk for diabetes and obesity. So keep that in mind when you're out there screening your patients, right? Here's your recap of your pathophysiology. If you don't have insulin to move the glucose into the cells, then your cells are starving and they can't get any, they don't have enough energy to metabolize and create more energy. This causes increased glucose in the blood, which causes it to spill into the urine. Once the blood is saturated, the cells starve. We're peeing out all of our sugar. We don't know what to do, so our body starts to eat its own self, meaning that we start looking to the muscle and breaking down muscle to try and find that energy. When muscle is broken down, ketones are released and they are eliminated through the urine and lungs, but when you have such an abundance, then your ketones cause acidosis in your blood, and then we start going into DKA. Once we identify that a patient is in DKA, we're going to do our A1C, urine dip, fasting blood sugar. Usually we're able to identify very quickly when a patient is in DKA because they kind of come in stupors and they have that fruity smell in their breath and they're not making a lot of sense. So we do that really quick AccuCheck, and then we go and we start drawing bloods for all these other things. We're going to do glucose tolerance test on the other side of the DKA management. But if you have that patient rolling into your pediatric emergency department, your go-to is not insulin. Your go-to is going to be to start an IV and hang 0.9 normal saline, because children in DKA are very dehydrated. And instead of giving them a rapid bolus of insulin and trying to bring that blood sugar down, we want to bring it down gradually. We want to start moving the glucose into the cells, start slowing down the utilization of the muscle for energy, and we want to start rehydrating it. And we want to do it all very, very slowly, because if you start making rapid changes, you can move those patients into danger the other way by causing them into hypoglycemia, right? And we don't want to ping pong them back and forth. We want to bring them down gradually. So we usually use a 2-bag system. We start that IV, we get that 0.9 normal saline running, then we piggyback on insulin and glucose onto that. So as we're weaning down the 0.9, we're ramping up the insulin and we're bringing in more glucose beside it, so we can keep very close tabs on where that sugar is and slowly march it down, very slowly. We want to make sure that we are keeping everybody off seizure thresholds from having sugars too high or sugars too low. And then once we have them stable, then we will start turning them over into insulin injections, right? We'll start trying to figure out what that long-acting insulin should be and what that short-acting insulin should be, and we'll have sliding scales to work with them. Nursing interventions obviously are going to be to monitor labs and vital signs very, very closely until we have them stable and off those two bag fluids and into their long-acting and short-acting insulin. We want to make sure that we have an entire multidisciplinary team giving their input. We want nutrition, we want pharmacology, we want social work, we want case managers, we want nutritionists, we want everyone there at the table to make sure that we have the best plan possible. When you are taking care of these patients, nurses have a lot of education to provide. In pediatric patients, it can take up to 3 full days to get patients stable and to provide all of that education. Here you see a lot of it. It's carb counting, insulin administration, blood glucose monitoring, what to do in an emergency situation. What is the sick plan? If that child gets sick, are we going to sit there and keep giving the same dose of insulin? No, we're going to probably start monitoring that blood sugar a little bit closer. We're going to make sure that we have a sick plan. Does that mean backing down on the insulin or moving back to a sliding scale? Or is it start looking for other alternatives to get nutrition in them to try and support their standard plan of care? Remember that when you have these diabetic patients who are exercising as teenagers, preteens, even school age, they're going out for recess, they're very active. You want to make sure that you have snacks available for them. We don't want to sit here and just increase the insulin every time they're going to go run a marathon. We might want to make sure that we have lots of extra snacks around. That way we have safe exercise plans as well, and endocrine really does that. It's not our job to really identify what those plans are. Our job is to find those plans out from endocrine and nutrition and encourage and support the parents through their understanding of it. So the last part of this discussion is diabetes, ketoacidosis, right? It is a pediatric emergency. It results from progressive deterioration from dehydration and increased ketones in your blood system, causing acidosis. It's an electrolyte imbalance. The acidosis will eventually lead to death if untreated. Usually with ketoacidosis, you're going to see blood sugars 4, 5, 6, 700. The higher it is, the more dangerous it is. Usually these children that you see are those who are being diagnosed for the first time. So we will be talking just a little bit more about it, but you should have gotten a lot from Med Surg class. So let me know what questions or concerns you have, and I'll give you some stories and case studies to help explain further. Have a great day.